My patients get great results with the LENSAR because I'm very fortunate that the machine has the ability to take very accurate topography and very accurate astigmatism measurement with the Cassini topographer, and to have that information wirelessly transferred into the laser, and then it performs an iris registration maneuver so that the instrument can perform the astigmatic incisions exactly on the correct anterior astigmatic axis. When we bring the patient into the operating room, the docking is quite simple. We generally tell them ahead of time what to expect, and we give them some Ativan. So we generally don't have much anxiety there. So the patients are pretty cooperative, they're very comfortable. It's not difficult to dock the patient. And when we bring the interface down, we make sure that it lines up with the anterior corneal surface, and then we lock the interface device in place, and then the camera will scan around the front of the patient and will begin to take the images. And when the images scroll through, it's very important that if you have this device that you pay attention to every image. You want to make sure that every surface is properly identified, because if it's not, you either need to go back and correct the surface of the image that is not properly identified, or you can simply eliminate that image from the 3D reconstruction step. So once those images are taken, then you process into your 3D reconstruction, and then it will go into the iris registration maneuver. The data that you have pulled over wirelessly from your topography will then very, very quickly, almost instantaneously, it takes virtually no time, and there you have it. Your axis is aligned, and you can roll right into your treatment. Your femtosecond laser first performs the capsulotomy, and you can watch it roll right through. The capsulotomy is performed, then it performs the fragmentation procedure, and then it will image the cornea right before it applies the astigmatic incisions. And then it will do so for each astigmatic incision. So it does one image for each of those, and then also it takes separate images right before it performs your clear corneal incision. The whole procedure takes approximately 2.5 minutes, and then the patient can be prepped for surgery. One thing that I've been particularly happy with the LENSAR is the performance when it comes to the anterior capsulotomy. I have found that their anterior capsulotomies are particularly strong, and when I have hydrodissection and my lens prolapses up through the anterior capsule, my anterior capsules don't break. And I like that because with my surgical technique, I generally prefer to flip and split the lens at the iris plane. And so I've appreciated that. There was sort of a scare where the femtosecond laser potentially created a weaker anterior capsule because of the laser not making the capsulotomy smooth, which under electron microscopy it's not as smooth as a tear, and these different studies had come out, and then there was a certain study that showed there was a higher tear rate with a different laser, not the LENSAR laser, and so I had some caution regarding that. And I have to say, I've been using this laser since 2012. I've done over 500 cases. I have not had any issue. It's really great to have this technology because I can be very, very confident that my treatment has been appropriately laid down, so that I can open all of my incisions with confidence, knowing that I have good data going into the operating room that I can trust. I think the new software with the Cassini topographer has been much more accurate. I like the total corneal astigmatism measurement because it factors in both the anterior and the posterior corneal astigmatism, and I get very few refractive surprises. I just looked at the data numbers, so I'm very, very happy with that. And I treat up to about 1.7 diopters of corneal astigmatism with the femtosecond laser. Higher than that, I'll go with the toric lens. And one of the things that is really nice that the LENSAR laser can do at this point also is it can put down an intelliaxis mark. It'll put marks in the cornea with the femtosecond laser right on the anterior axis of astigmatism. So when I'm in the operating room, I have, in retroillumination, I can see exactly those marks on the cornea and place my hash marks for my IOL and line them up exactly correctly. When I'm treating astigmatism with the femtosecond laser, I prefer to make my incisions paired. And so when I'm treating, against the rule, astigmatism, I generally don't make a clear corneal incision with the femtosecond laser. I prefer to make that incision manually, and I try to take into account my surgical induced astigmatism with that and adjust those femtosecond incisions slightly, even though my SIA isn't very high. But that is one thing that I prefer to do, because when you're looking at making your clear corneal incision with the femtosecond laser, the way you have to position it in order for all of the incisions to be made correctly is just a little too far away from the astigmatic incision for everything to fire off correctly on the laser. The reason I like to use the LENSAR femtosecond technology for correcting astigmatism for my patients is because it's simple and it's accurate, and I can take the good data that I get in my clinic and I can know that that data is accurately applied to the patient's cornea at the time of surgery.